Okay, we're going to be talking about now your last chapter before your test, which is your health records and health information management, which is chapter 25 in your patient care book. So you have some objectives. Make sure that you're able to answer all the objectives that are listed here and the questions in the back of your patient care chapter. So the first thing is your health information management. So all healthcare providers, regardless of the setting, are required to maintain all patient care information that applies to an individual patient. So these records concrete within a single record all patient care information that applies to an individual patient. So everything we do to a patient needs to be documented. So the information is to be maintained for 5 years from the last date of visit. Mammography is a little bit different where it's 10 years that we need to maintain the records, but if they had a mammogram every year at our facility, we can then only keep the 5 years. So you'll have 5 years worth of mammograms on file at your center. So record requirements are established by accrediting agencies like the Joint Commission and the American Osteopathic Association. Records promote effective communication amongst all healthcare providers, so it's a continual flow of information so everyone is on the same page. So health information department functions, so they support the current and continuing care of patients. They support the institution's administrative process. They maintain records for patient billing and accounting processes. And they support the medical education programs. And they support health services and research. They maintain records for utilization management, risk management, and quality management or performance improvement programs. So they have a lot to, they collect data for all the quality improvement programs. They ensure patient privacy and security issues through HIPAA is typically how they do it. They ensure that HIPAA is being enforced. And they ensure compliance with legal requirements. So if a chart is subpoenaed, they'll provide the necessary documents for the court case. They perform other extenuating patient services in addition. So HIPAA is the Health Insurance Probability and Accountability Act. It was passed in 1996. There's been an addendum to it since, but it is basically securing the rights of confidentiality. So we're going to go into health information terminology. So the APC, which is the ambulatory payment classification, the CPT, which is the current procedural terminology, I love it, ICD-10 CM, which is the International Classification of Diseases. The 9th edition, there's the 10th edition now, so this is a typo within the PowerPoint, so I apologize for that. The DRG, which is the Diagnosis Related Group. TJC is the Joint Commission, and PPS is the Prospective Payment System. So the APC, the Ambulatory Patient Classifications, based on ICD-10 CM codes for diagnosis and CPT codes used for reimbursement to healthcare in the outpatient center. So what is a CPT code? So it's a current procedural terminology, and CPT-4 is what we're at. It's a listing of medical terms and codes for diagnostic and therapeutic procedures used for coding for physician reimbursement, used both for inpatient and outpatient. So we always ask what the CPT code is. At some of your facilities that you're going to work, you're going to have to actually put in the CPT code, so you'll become very familiar with cough is and pneumonia and small bowel obstruction, so you'll know what that CPT code is, so you could pop that in. So the International Classification of Disease, the 10th edition, and the CM is the clinical modification. So it's a classification system that is used for diagnosis coding in all healthcare settings in the United States. So they proposed to come out with ICD-10, and we were using ICD-9, and it got delayed. And everyone that we trained at Mesa was on ICD-10 in health information's management. So we had to go back and train them on 9, so they knew 9 and 10. I think 10 is officially out now, and they're using 10. So we use ICD-10. So you'll still hear people refer to ICD-9. 9 is just the older version. 10 is the newer, updated version. So the DRG is the diagnosis related group. It categorizes into payment groups patients who are medically related with respect to diagnosis and treatment and statistically similar with regards to length of stay. So when a patient gets admitted to the hospital, we have a DRG. So they fall into this category, and there should be a treatment plan based on that diagnosis. So and you're paid by your DRG number. So if the patient's admitted for diverticulitis, there's a DRG for diverticulitis, and it says how long that they're going to pay for the stay and what kind of treatments they'll pay for. So that's a DRG. So the Joint Commission is an organization that accredits hospitals and other healthcare institutions in the United States. When Joint Commission comes to the hospital and you guys are students, we usually have you out of the department. There's a lot there that goes into it, and it's the accreditation on the line. So we prefer that the students are not there. We send you to lunch, we send you to the outpatient, we send you anywhere but in the department. So when you're a technologist, you will be asked questions by the Joint Commission and you'll have to answer them. So prospective payment system, so PPS, is a system for Medicare patients whereby payment groups are established in advance and the hospital gets paid up front. So that's a PPS, they get paid up front. So EMR or EHR is the electronic health record system, generally considered as the portal through which the clinicians access a patient health record, other treatments or therapies, and document care delivered to the patients. It allows for the provider to gather multiple types of data about a patient. So this is the electronic version of a paper chart. It's all online. Everyone's going to this. It's surprising that San Diego's a little delayed. I heard that Scripps is actually going to an EMR, which is really good. You'll love it once you use it. All right, so according to the Joint Commission in Healthcare Facilities Accreditation Program, a medical record must contain sufficient information to identify the patient, support the diagnosis, justify the treatment, document the course and the results, and promote the continuity of care among healthcare providers. So you get dinged if you do not have all of those within your charting. So it's important when the patient comes to radiology that you do document in the chart, chest x-ray done, you know, and you can look at prior chest x-rays, you can look at the reports, you can look at, you know, the medications the patient's on to see if you can stand them, to see if they're on, you know, opiates or whatever. So really good way to follow a patient. So according to Medicare, the medical record must contain information to justify the admission and continued hospitalization, support the diagnosis, and describe the patient's progress in response to the medication and services. So a little bit different than the Joint Commission. Joint Commission is typically the most strict, and whatever the Joint Commission says, Medicare or Medicaid services is usually supportive of it. So if you do not have your Joint Commission accreditation, a lot of times you won't have Medicaid or Medicare accreditation. Okay, so health record content. All departments that take part in the care of a patient must document that the care in the hospital. So whatever you do to the patient, you have to document that you did it. So if you have a paper chart, it says chest x-ray, you know, portable chest x-ray, you're going to write in there complete with the date and sign your full name with your initials. So your RT or student radiographer, and then you'd put your technologist name with it. Documenting in the patient's record or charting should be done by the radiologist or radiographers when a patient receives their diagnostic or therapeutic radiology services. So if you have EMR, you're going to go in and put in under the chest x-ray done. So, and then put your name and initials. For documentation of medical necessities, a diagnosis or sign or symptom for which the test is being performed must accompany each request for procedures ordered. So when you get an order for a patient to come down for an x-ray or an outpatient coming in from a doctor's office and they have the order, but it just says chest x-ray and it doesn't say the reason why, you cannot proceed. So you have to have a sign or a symptom, diagnosis, sign, symptom on the order in order for you to do the image. It also has to be signed by a physician. So if you are missing any of those, you cannot do the procedure. You have to call the office, you have to call the doctor and get a reason for the procedure and get them to sign the order also. All right, so medical record information. The health record per the Joint Commission, so it's a little bit streamlined for you. So must contain sufficient information for identifying the patient, supporting the diagnosis, justify the treatment, documenting the course and the results, and facilitate continuing care. So those are big topics. That's what they're looking for when they're going through the charting. All right. So medical record information, it should all have patient ID and demographics, medical history, conclusion and impression on admission, diagnostic and therapeutic orders, clinical observations of the nurse and the doctor, report of relevant physical examination, so an examination has to be done on every patient, consultation reports from the doctors and the nurses, diagnostic and therapeutic reports from the radiologist. It has to have a final diagnosis and prognosis, so not only the diagnosis but the prognosis, so what is the outcome, what is going to happen with this patient moving forward. So the diagnosis is pneumonia, the prognosis is should be better after rounds of antibiotics, whatever. So it needs to have a discharge summary, a post-mortem results if there needs to be, psychological needs summary, so if there's any psychiatric needs of the patient, it needs to be summarized within the report. The chart, physical examination report, treatment plan, evidence of informed consent. So that's important. So if the informed consent is not within the chart, you have to chart where it's at. So if you say the informed consent is within the RIS system and PACS, that's fine, but it has to be charted within the medical record as to where it's at. There needs to be progress notes from the nurse and the doctor, and radiology. So if the patient comes in and we have the patient for a while, we can do progress notes on the patient doing well, patient tolerate procedure well. In MRI, we do this all the time. So patient did not tolerate procedure well, recommend bringing patient back tomorrow, whatever. Records of surgical and invasive procedures, records of donation and implants, conclusion at termination of stay, and discharge information given to patient and family. So that one is really important. So after we have a patient in MRI and they're an inpatient, we send them back upstairs, we will go ahead and discharge them from the MRI. So if sometimes it's discharge pending MRI, so we will make sure that we put in that the patient is finished with the MRI and the nurse will go ahead and do the discharge and give everything to the family and the patient. So really important that that happens. Okay, radiology health records. So this is within radiology. We're looking at the patient's demographic information, specific procedure requested, ordering physician, documentation of medical necessity, signs or symptoms on the order, procedure results, so we're looking to make sure that there's results in there from any procedures that we do. The dosage is required for therapeutic and radionuclide procedures, so that has to be in there. Whenever we do a CT or MRI, we put the dose in also. So in CT, we put in the dose of contrast we give along with the dose that we gave in radiation. And x-ray, they're also starting to do that. So if you do a chest x-ray, sometimes the radiologist will dictate the dose that the patient received, so within the report. And that's going to be a trend you're going to see more and more moving forward. Special reports documenting evaluation and treatment of a patient. So like I said, sometimes we'll have the patient for a while and we'll document how the patient did, how they tolerated the procedure, just kind of give the nurse and the doctor what is going on with the patient while they're within radiology. Okay, recording information in a medical record. What should you do? You need to write legibly. You have to write in blue or black ink. You are not allowed to use any other color. Use correct spelling and standard abbreviations. There's been a lot of abbreviations that were taken away that were confusing. So there's a list of abbreviations you're allowed to use. Write accurate information precisely and correctly. Do not go into huge details. Just write exactly line by line what happened, real short, precise information on the patient. Keep the information concise. They don't want a novel. They just want to know. Patient tolerated chest x-ray well. Patient brought back to room. Patient put back in bed. Patient stated needed nothing else. Informed nurse. Patient back in room. So you release yourself from any liability. Okay, so don't write in pencil. Do not block out or erase. You're not allowed to use whiteout, period. You're not allowed to scratch out whatever you wrote, and you're not allowed to erase whatever you wrote. What you want to do is put a line through it and write error, and then write it again, what you want to say. So you're not allowed to enter any unnecessary details. So we just want precise information related to the patient only. They don't want to hear a novel about the family. They don't want to hear any of that. This is only about the patient. Include critical comments about the patient or other healthcare professionals. So do not talk about, well, the nurse said, none of that. So this is just about the patient. Okay, so the dues to continue. Begin each entry with the date, the time, and that's military time of the event. When I first started in radiology, I didn't know military time. I went and bought a watch that had digital military time. Perfect. Got it. So if you don't know military time, you're going to want to go do that so that you know your military time. So each entry starts with the date. That's the first thing you're going to put, and the time. So record the information as it occurs. So it should be in chronological order. Keep the information confidential. So you are required by law under HIPAA to keep all the information confidential. And you sign each entry with your name and your title. So Christy Foster, Bowman, RT. So that works perfectly. What you don't want to do is leave blank spaces in your notes, because what happens is people go back in there and fill it in whatever they want. You don't want to do that. You want to make sure each line is used. Do not use convenient abbreviations. You need to use the abbreviations that are on that list. Do not record information for someone else. So if you are doing a small bowel study and you ask someone else to put it in the chart that you're done, you're not allowed to do that. The person who does the study needs to chart the patient. You're not allowed to divulge information concerning the patient that has to do with HIPAA. You are only allowed to talk to someone else that has direct patient care with that patient. Otherwise, you are not allowed to talk about that patient. It's a little bit different with Jill and I in the sense that we're education. So if we ask you to bring up a case or tell us about the trauma that came in, we're not looking for details about the patient. We're looking about details about the studies. So there's educational exemptions for us to be able to talk to you in an educational setting about the patient's condition and treatment. So I don't want to know that the patient was pregnant, and she had a broken ankle. That it doesn't have anything to do with her broken ankle. So, we only want pertinent information. And do not just use initials when signing your name. You need your full name with your title. Okay, standards for inpatient records. So the patient identification data has to be there, your medical history of the patient, including chief complaint, which is the reason why they came in. Okay, it may not be what ends up being, but their chief complaint is abdomen pain, but then they had a stroke the next day. So the chief complaints, they came in with abdomen pain. So present illness or injury, relevant family and social history, and inventory of the body system. So they go through and do a physical. Report of relevant physical examination and diagnostic and therapeutic orders. So the The clinical observations have to be in there, including results of therapy. So if they have any physical therapy, any radiation therapy, anything, the results need to be in that chart. Reports for diagnostic and therapeutic procedure tests, as well as the results, evidence of appropriate informed consent. When consent is not obtainable, the reason should be entered in the record. So if you can't get the informed consent, you need to have two physicians sign off saying that this is medically necessary for the patient, or you have to chart that that's the case. So there's certain things that you're going to learn as you go through this program and while you're in the clinical setting, that there are times where we do not get the informed consent, but we need to enter why we could not. So it covers everyone's behind. The conclusion at termination of the hospitalization or evaluation of treatment, including any pertinent instructions for follow-up care. So the reason why this is in here now is we used to send patients home and they had no idea what they were supposed to do at home. So now we have to document what the follow-up care is for these patients. Okay, so informed consent. The Joint Commission requires it. The policy on informed consent is typically developed by the medical staff and the hospital governing board. It consists consistent with legal requirements of appropriate informed consent. So there are legal requirements for the informed consent. Informed consent states that the patient has been informed of the procedure or operation to be performed, the risks involved, the possible consequences of doing the procedure, the risks of doing nothing, and alternatives to the procedure. So not to be confused with implied consent. Implied consent, as we talked about, is just the person walking in for a chest x-ray. That's implied. The patient coming down for a barium enema and they let you tip them. That is implied. This is informed, which means we're doing something invasive. By signing the consent form, the patient or the patient's representative indicates that he or she has been informed and consents to the procedure or treatment. Now, we need to write this at a very, very low level. We'll put in there, like if we're doing a lung biopsy, taking a needle, placing into the tumor within the lung, and taking a sample of the tissue of the tumor. So I write it just like that so that they know exactly what we're doing. All right. So also, the informed consent is not the same as authorization for treatment. When the patient comes in to the hospital, they sign an authorization for treatment. And that's a blanket consent form stating that we can do the chest x-rays, we can do the small bowel studies, we can do the BEs, we can do whatever we need to for the patient. But when we're doing anything really invasive, we need the informed consent. So the authorization for treatment is just a blanket authorization allowing us to treat the patient by implied consent. But we do have the backup paper trail of the authorization for treatment. So if the informed consent is not filed with the medical record, the record must then indicate that the informed consent was obtained for a given procedure and a treatment, and the record must indicate where the informed consent is located. So a lot of the times when we do a procedure, we scan it into our PACS system, and then I just put into the EMR that informed consent is within PACS with patient study. So, and I'd put the study number, so the PACS number in there, so that they would be able to relate it. That way you're covered, but if you don't put it in the patient's chart, which is really hard to do sometimes with the EMR, finding a scanner, the informed consent is, a triplicate thing, it doesn't fit, so I don't like the risk of it getting lost, so I'll go ahead and scan it right into the PACS system, because sometimes we can't scan into EMR. All right, an incident report. We talked about this a little bit. It contains information relative to a patient's incidences or occurrences that are out of the normal experience. So the incidence is classified as a sentinel event. It must be completed after the event. So the reports themselves should not be part of the patient's record. And it's administrative record and it's used for risk management. So it's a report, and anything weird that happens with the patient, you should fill out an incident report, because if the patient comes back to sue, they can look at the incident report and see a detailed account for what happened. So this incident report will usually cover your butt, and it will provide you with all the relative details that you need for court. So important that you fill it out. And it also lets them know if there's something that they can do in the hospital to prevent someone from getting hurt again, they need to know that. And they'll send out a risk management team and they'll go ahead and fix whatever the issue is so that it doesn't happen again. So if the lock on your tube is not locking all the time and the tube fell and landed on a patient, and hurt the patient, then you put in an incident report, and of course you notify everyone that the patient got injured by the falling tube, but you put in an incident report with all the details. They'll go ahead and they'll look at that, and then they'll see what's going on with that tube head, and sometimes you can get stuff fixed by putting in an incident report if your manager won't do it. All right, so radiology records. Before a radiologic procedure is performed, a radiology order or request for service is completed. A diagnosis or sign or symptom for which the test is being performed must accompany each request. You need to have the results of the procedures. Also in the chart, any special reports documenting, evaluating, or treating of a patient must be made as part of the patient's permanent record. Okay. So health insurance companies. So medical records contain sufficient information to support the diagnosis for reimbursement purposes under the diagnosis related group, so the DRG, and the prospective payment system, PPS, implemented by the government in 1983. So failure to record data. As I said, it has to be in ink. And if the electronic medical record system is used, authorization to record data must be verified. So you have to have a login to be able to get into it. It's got to be secure. So without the requisite documentation in the health record of what was done to the patient, the assumption is that the event did not take place. So if you do not record it, sign it, date it, write it in ink, it never existed. So all of those things on doing the proper charting have to be in place in order for it to count. And if it's not in there in the proper way, it can be as if you never did it in the first place. All right, health record reimbursement. So your prospective payment system, so your PPS, so you have your DRG and your APC. So your DRG is within the hospital, and APC I think is outpatient. So read that and make sure that that's correct. So we also have the ICD-10 now, and correct billing is critical to reimbursement and financial health of organizations. So if you have a really good billing and coding department, your hospital is usually going to do well. If you have a terrible billing and coding department, what happens is the payments or the studies keep getting rejected and they're not being paid. So it makes it very, very economically unstable for an organization if your billing and coding team is really poor. So performance improvement. It's a process that monitors and evaluates the quality of care and services provided to patients within a healthcare facility. It's also known as a quality assurance or quality assessment. So they look at a lot of different things, infection control, medication usage, blood usage reviews, pharmacy. Pharmacy comes through all the time and makes sure that our counts are right. There's case management, hospital department committees, radiation safety committees. There's a ton of committees. So the director of every facility is very busy because they're on probably 10 different committees ensuring the quality assurance of the hospital and the department. Quality improvement programs, they set benchmarks. The committee activity is typical. So what they mean by that is they usually have a ton of meetings. They're in the department, they're going through our stuff, they're making sure that the data is correct and that we're doing the right thing. So the Joint Commission requires the medical and professional staff to participate in review functions. So some of those quality improvement programs, they look at our mission or values, our objectives, our leadership, our organizational structure, methodologies, performance measures. Those are the big ones. Are we failing in an area? If we are failing in an area, what are we doing to fix it? So that's really big with the Joint Commission right now is if you are not doing well, okay, fine, what are you doing to fix it? So, and then part of the other piece of that is communication back to the people stating, okay, this is what we found, this is what we want to do to improve it, or yes, you improved. And so the communication loop, closing that completely. They found that they were not closing that loop. So, and the annual plan review. Okay, so legal aspects of records. Health records are considered legal documents. Radiographers may be required to give depositions or testimony regarding information in the health record, or in the case of a radiograph, testimony regarding the procedures involved. So really important that you guys document well. The proper method for correcting an error that the author makes is the author to draw a single line through the error. Write error in capital letters next to it so that they know that you screwed up, and you should sign it and date it, that you wrote that, you crossed out and you wrote error. So if you accidentally grabbed someone else's chart and you wrote in patient tolerated procedure well, called nurse on floor, patient transporting back, and you sign it, and then you realize, oh my gosh, that's the wrong patient. I did a CT on that patient. So you'd put a line through it, you'd write error, and you'd sign and date it. So health records are considered to be confidential. So that's the HIPAA. You are not allowed to discuss anything about that patient with anyone unless they have direct patient care with that patient. The original record is never left in court, so we make copies. Informing patients of examination results is the physician's responsibility and not the technologist's. So you need to have the physician or the patient's physician give the results. You are not allowed to do that. So that is a huge no-no. So you can look in the chart and see the patient has AIDS and lymphoma and whatever, but you are not allowed to say a word. And sometimes that gets a little tricky. Don't be shy in grabbing your radiologist and have them come in and speak to the patient, because they can give the information. Most of the time they don't like to, but they can to get you through your exam. All right, HIPAA clearly outlines the confidentiality requirements of health records. So make sure you don't break any HIPAA rules and regulations, and we'll keep talking about HIPAA for the next 2 years. The health record is a legal document that is admissible as evidence in court. Okay, so ownership of medical records. It's generally accepted philosophy regarding a patient's medical record that is the caregiver or facility owns the record, but that the patient has a right to the information included in the reports except where prohibited by law or the patient's medical condition. It's important that a department or facility work with a health information professional or risk manager to ensure that a release of information, consent form, and policies are consistent with HIPAA requirements. So we can actually hold a patient's records if it's news that's they're terminal with cancer and it's really bad and they're gonna die, if we find that the patient is not stable. There are times where the doctors will document certain things on a patient, mentally unstable or whatever, and they don't want the patient to see that, and they are able to block parts of the chart. So it's a generally accepted philosophy that the patient's medical record is owned by the facility. The patient has a right to review all the information though. All right. So record maintenance. Medical images must be maintained in a secure area with limited public access. So patients are not to be walking by and seeing on a PAC system someone's image. It needs to be secure. You need to log out of your computers. You're not allowed to have an x-ray hanging in a public area. So the patient should be escorted if they're in an area where there is patient information so that they don't stop and read. Copies of written interpretation should be maintained with the images as well as the patient's medical records. So with the PACS system, it should have the images along with the report. Patient's records and images may be stored off-site if economically feasible and security is maintained. So with our PACS system, we have servers on usually the facility site, and they need to be behind 2 locked doors. So a door can have 2 locks on it, that's fine, but there has to be 2 locks to get to the servers. They have to be secure. There should be an alarm within the room also, so if someone goes in there, it sets off the alarm. Also, the data is supposed to be stored off-site. So if the hospital gets blown up or a huge fire, an earthquake flattens it, all the patient's records are still intact because they're stored off-site in a secured location. So there's huge warehouses with tons of computers that are storing all of this data for patients. It's crazy. Huge money in this. All right, so the conclusion. The Health Information Management Department is a key hospital department. The health records is the documents that communicate information pertaining to the patient. The proper coding is an essential part of the health record and critical to the financial viability of the institution. The health record is a legal document that attests to the care that was rendered to the patient. In this world of electronic media, health record confidentiality is critical to care and legal requirement with very harsh penalties for noncompliance. Every time you log into a case, your name is logged for that case that you saw it. So if Britney Spears comes in and gets a chest x-ray, you look at that case, your name is logged, and if she says, you know what, I feel like there's a HIPAA violation, I want to pull anyone who's looked at my case, they can pull it, and if your name is there, she can sue you. So it's expensive. You will be fined. You will lose your job. The hospital will be fined. It's a mess. Don't be tempted to look at anyone's images that are not directly related to yours. Now, for education, your CI and your clinical coordinators are allowed to look at the images because there's an exception in there for education. So we are allowed to look at it, so don't panic. We don't want to know details that aren't relevant or pertinent to the image. All right, so there it is. Make sure you read the whole chapter and understand everything required for your health records and health information management.